right, good morning, everyone. It's really a pleasure to be here in San Antonio during ObesityWeek 2024 among our distinguished panel. And we have a jammed agenda this morning talking about new insights into peripheral CB1 inhibition to treat obesity. Really appreciate everyone that's going to be here today. You're going to be well informed, and hopefully you get to apply that knowledge and you continue to help advance the research, whether you're an investor or you're a clinician or a researcher. We're certainly here together to bring some of these exciting medicines to the market and ultimately impact the end user. I'm going to be making some public statements or forward-looking statements. As a reminder, Sky is a public company. Please note to look at our risk factors and our SEC filings. So there's been an incredible amount of momentum over this past year when it comes to our development. Sky's been firing on all cylinders. Nimacimab, our first-in-class peripherally restricted CB1 antibody inhibitor. There's been basically three primary areas where we've been continuing to focus on R&D. One of them that's not mentioned on this slide has been the CMC and drug supply. So all of our requirements for phase 2 were met, and we are currently scaling up our manufacturing to support our subsequent clinical programs. And then turning over to clinical development, our main job has been to launch our phase 2 CB1 study, which is currently underway. We're on track to enroll 50% of our approximately 120 patients before the end of the year. So we're looking forward to sharing the first data from this clinical trial in the middle of 2025. And we're also continuing to advance research to better understand nimacimab, and as you can see on this slide, there's been several kind of sequential steps that have been taken, that culminated in a PR we issued yesterday, highlighting significant weight loss using nimacimab in a diet-induced preclinical obesity model. And that's going to be the focus of today's presentation, and that'll be the foundation of some of the other data that you'll see from the group over 2025. So as has become evident based on the momentum in obesity and metabolic disease therapeutic areas, there's definitely a world beyond GLP-1. Yesterday, I guess once again we saw a lot of different new data points on GLP-1, also incretin combos. There's really an exciting opportunity here in terms of CB1 receptor through inhibition. This receptor offers a very broad opportunity in terms of demonstrating broader metabolic gains as well as weight loss. And I could say that there's certainly been a renaissance moment here for CB1 inhibition over the last year because of the clinical progress that Sky's had, as well as the clinical development that Novo's been working on. Over the last year, there's been several questions that continue to come up, and I wanted to kind of bring that to the surface again, just so we're all on the same page into today's presentation. One of the questions has been, is targeting peripheral CB1 receptors alone sufficient to drive clinically meaningful weight loss without significant side effects? The other question we often get is, do we need to target central CB1 receptors for weight loss? Why haven't we seen weight loss with nimacimab yet? What can we learn from the rimonabant experience? That's the first generation small molecule CB1 inhibitor that was previously launched by Sanofi, or previously marketed by Sanofi. And what insights does monlunabant data offer, the second generation peripherally restricted small molecule being developed by Novo? So we're going to answer all of these questions today and more, and we want you to kind of take away three important points when you're listening to the presentations today. One of them is making sure that there's really this appreciation that there's limitations really of central CB1 receptor inhibition, in that central exposure really drives the neuropsychiatric adverse events and does not significantly impact weight loss. Second important takeaway here is that there's really a critical role of peripheral CB1 receptor inhibition. So we're going to talk about that and its link to weight loss. and that there's really an opportunity for efficacy of peripheral CB1 inhibition, that nimacimab is truly a peripherally restricted CB1 inhibitor that can significantly reduce weight, and we're going to talk about that DIO data and how it translates into our ongoing clinical program. I'm going to introduce the panel really briefly today. So on the far right, we have Dr. Lou Aroney. He's a leading authority in obesity and its treatment. He's a Sanford Weill Professor of Metabolic Research at the Weill Cornell Medical College and directs the Comprehensive Weight Control Center at a state-of-the-art multidisciplinary obesity research and treatment program that he founded actually in 1987. Dr. Aroney is going to walk us through the history of CB1 in obesity and bringing us all the way to the present data from monlunabant. Unfortunately, Dr. Marcus Gonsalves couldn't make it today, but he's a physician scientist at the NYU Langone Health, and his lab is leading research in metabolic science. And today we have Dr. Puneet Arora, who's also an endocrinologist, and he's leading the clinical development of nimacimab at Skye as our Chief Medical Officer. So he'll be covering Dr. Gonsalves' presentation and talking about the mechanisms into peripheral sufficiency of CB1 inhibition. And then Dr. Chris Twitty is leading the research at Skye as our Chief Scientific Officer, and he'll be covering two presentations, one to discuss the clinical evidence of peripheral CB1 inhibition, and then we'll dive deeper into the preclinical evidence of nimacimab in our proprietary humanized DIO mouse model. So I'll turn it over to Dr. Aroney now.
Thanks very much, Puneet, and I appreciate the opportunity to talk to you all this morning. So before there was GLP-1, there was the cannabinoid system. So if you go back to the early 2000s, GLP-1s did not look like a very good target for weight loss. The reason was that people would have nausea and vomiting before they would lose any weight. So if you go back to the earliest short-acting agents, exenatide, for example, we tried it, but we really couldn't get very far. And back then, amylin looked like a better target for weight loss. But the best one was the CB1 system and rimonabant. Rimonabant at that time had a lot of promise. And I'm going to show you a little bit of data about the results of the Rio North America trial. I was one of the principal investigators on that. Show you what's going on now with monlunabant, and I think you'll see that there is some promise from this. So back in 2006, there was enough data from Sanofi to gain approval for rimonabant in the EU. It was never approved, however, in the United States. And it demonstrated weight loss up to 10%, and that was including the placebo weight loss. Placebo-subtracted weight loss was 7 to 8%. There were significant improvements in metabolic outcomes as well. So increase in HDL, reduction in triglycerides, improvements in insulin sensitivity, a lot of the things that we now look for in drugs, the rimonabant had that. It was removed from the market, however, after a short period on the market because an outcome study, a cardiovascular outcome study, showed an imbalance in the number of cases of suicide, more in the treated group. And as a result, multiple companies, Merck, Pfizer, and others, dropped their CB1 programs. And these were, back then, it was thought that you needed maximal central efficacy because there are many CB1 mechanisms within the brain, but these drugs were designed to focus on central activity. But here you can see this really great weight loss with 20 milligrams daily of rimonabant, a reduction in waist circumference of 8 centimeters, HDL going up, triglycerides very significantly better. So now we have monlunabant from Novo Nordisk, and Novo has been interested in many different mechanisms besides GLP-1. They see that the future is going to be more like hypertension, where there are at least 10 mechanisms and 100 drugs, they agree that we need a number of different mechanisms. And monlunabant is turning out to be an effective agent. It showed 7 kilos of weight loss compared to 0.7 for the placebo. It looks like the 20 milligram dose produces, or 10 milligram dose rather, produces as much weight loss as you're going to get. And by the way, we saw that with those earlier agents, that the lower doses produced as much weight loss as you would get. Even if you double the dose, there was no more weight loss. That's a little bit different from what we've seen with GLP-1s. There were GI side effects, but it was more tolerable. The neuropsychiatric adverse events were somewhat higher. This has been reported. I haven't seen the data. It hasn't been presented yet, but it was reported that they were higher with monlunabant. And a key point is going to be, what do these look like? What are they, and what do they look like? And a phase 2b study is set to initiate. If we look at the weight loss data, it actually looks quite good. It looks like, the 7 kilogram weight loss looks like it's better than rimonabant at a similar point in time of 16 weeks. And so here we see the monlunabant 10 milligram data, and you can see that compared to where rimonabant was, there's greater weight loss. Now, this is a large-scale phase 3, 2,000-person trial, and this is a very small pilot study. So you can't really compare them, but you get the idea. It's at least as effective as rimonabant, I would say. In fact, it's so effective that it's as effective as one of the gold standard compounds right now, which is injectable semaglutide. Right? So if you look at the weight loss at 16 weeks, it's very similar to where semaglutide is. So in summary, rimonabant was the first agent, and it produced very meaningful weight loss. It was taken off the market due to the neuropsychiatric effects. And there's been a lot of debate about whether it was the way the study was performed or whether it was really such an issue. Monlunabant, the new agent from Novo Nordisk, has shown positive weight loss data, but we still need to see what the neuropsychiatric side effect profile looks like, and we're looking forward to that longer-term data, and also DEXA data, because it looks like agents like this will have preservation of lean mass. Some of the early data looks like preservation of lean mass. And then finally, we're going to hear today about nimacimab, which is a CB1 targeted drug that is restricted from the brain. This is completely peripherally restricted, and I'm really looking forward to seeing the data that gets developed in the coming years about nimacimab. My belief is that over time, we're going to be using a lot more combinations, and that in addition to GLP-1s, while they are extremely effective, they may not be enough in a lot of circumstances, so that the combination of a GLP-1 with something else is going to be the preferred way to go. And this, in my opinion, would be a candidate. The CB1 mechanism would be a good candidate to put along with a GLP-1. Thanks very much. And now Dr. Chris Twitty will tell you some more about CB1 inhibition.
Thank you, Dr. Aroney, for providing that perspective on the monlunabant update. So in light of that, and more broadly the CB1 pathway, we thought it was a good time to address whether peripheral inhibition of CB1 is really critical to drive weight loss. So there's certainly some, I think, positive read-through, and we're also very encouraged, around the monlunabant data, but the questions remain, such as, why is the dose-dependent weight loss not seen with monlunabant? And relatedly, why are neuropsychiatric AEs seen at higher doses with this small molecule approach? And finally, maybe critically, what's the role of central versus peripheral inhibition? So by the end of the presentation, our modeling data, as well as our own clinical or preclinical DIO data, will demonstrate, one, that central exposure is the key driver of a neuropsychiatric AE and does not significantly impact weight loss. And two, peripheral inhibition of CB1 receptors are critical for weight loss. And finally, nimacimab is a very highly restricted molecule, can significantly reduce weight. So we'll demonstrate all three of those. Okay, so we can jump into the model. So break down the model. We use clinical data, and we looked at this in a few different ways to understand the relationship of PK and PD. And so the three components are first determining an inhibition threshold. So thinking about target engagement, and we needed to understand the inhibitory concentration, specifically the IC90. So we'll go through how we got that. There's the traditional pharmacokinetics to understand the peripheral compartment of the drug and how that behaves. And finally, the brain penetration, that is what leaks into the brain, and that would be our CNS distribution to understand the central compartment. So focusing in on the threshold concept. So what we did is looked at various published peer-reviewed articles from monlunabant. You can see the Liu et al. Publication we used, and we were able to extract the dose curve from that. And we used various fitting methods to get a really nice curve. And we looked at this all different ways. And similarly for rimonabant, we used a more recent publication noted here. And again, different fitting methods to arrive at a very nice IC90 value. With monlunabant, we used our own internal data. This is a qualified commercial assay that's used for a potency assay in the clinic for us. We benchmarked this internally against the noted publications here. Pivoting to pharmacokinetics. So here we use, for monlunabant, we use the Crater et al. Publications, the phase 1 study that was published last year. For monlunabant, we used a study from 2015 that laid out a nice PK model. And then again, for nimacimab, we had a phase 1 sub-Q dosing study in volunteers with obesity or that were overweight. The PK models were then confirmed for consistency where possible externally or internally if needed, and as well as using SKY data for nimacimab. So you can see here where we went back and sort of made sure that those were aligned internally. And lastly, for the CNS, the brain distribution, we use ratios that were published for monlunabant, again going back to the Liu et al. Publication, noting the more conservative 7%. That was the acute dose. If you recall, there was chronic dosing that was higher, so keep that in mind as we look at the models. For rimonabant, we used a 2011 publication, and for nimacimab, we used a series of non-human primate biodistribution studies to arrive at our 0.02%. Okay, so jumping into initially looking at the peripheral exposure with monlunabant, it's clear that we're seeing 3 doses here at 10, 20, and 50. And what's clear is that all 3 doses exceed that IC90. That's meaningful target engagement and essentially complete inhibition of the CB1 axis. So the fact that even the lowest dose is able to achieve readily that IC90 threshold speaks to the fact that you're not seeing any increase in efficacy as you have sufficiently shut down that axis. So this aligns well with the NOVA release and what Dr. Aroni just walked us through. So we believe that peripheral inhibition is key to efficacy. And I would just draw your attention to the right here where we look at the 200 milligram dose of nimacimab. This is our current clinical dose that's in phase 2 right now. We've also modeled alternate dosing at 400 mg, whether biweekly or monthly. And all of these you can see are well above our own IC90 threshold here in the dotted line. So ultimately, we think that the concept of peripheral inhibition is key, and that monlunabant clearly exceeds that threshold across all doses. Now, in contrast, if we look in the central compartment here, we're looking at monlunabant in the brain. We see a different story whereby the 3 doses are still stepping up as you would expect from a dose titration. The lowest dose is sitting right about IC75, well below that threshold. And as you increase the dose, you're moving closer to that IC90 and eventually surpass that meaningful target engagement at the 50 milligram dose. And again, this also, I think, lines up nicely with the phase 2 update that Novo provided in that there is a dose-dependent increase in neuropsych as you get meaningful target engagement seen here. Now, in contrast, I want to highlight that nimacimab is very different. So here we're looking at a similar profile, PK profile, but we simply cannot really show how much is in the brain. We did use non-human primate where often there was below detection, but we chose the monkeys that had some nimacimab above that level, we broke out a little window here so we can actually see what's there. But the bottom line is we're essentially greater than 600-fold below that meaningful IC90 threshold. So even with a large dose, playing with a very high dose in the clinic, if we wanted to use that flexibility, we simply are unable to get near that meaningful target engagement with the nimacimab. So collectively, if we think about this concept, pivoting back to the small molecule approach, all indications suggest that there's no real benefit by driving more and more of the small molecule in the brain in terms of getting that target engagement. We don't have a therapeutic benefit, but we don't see, if you go back to the peripheral, we don't see any gain with that same titration. So really, it's sort of this concept of liability through increasing brain exposure. That leaves open the possibility, however, that potentially you need something in the brain. There's some level of inhibition, whether that's IC50, IC75, that's required for some kind of efficacy. So we looked at this in a different way. We went back to the Rio study that Dr. Aroni was just walking through, and we asked a similar modeling question. So here now, the first question was, does the PK profile of an ineffective dose, so we're going to start with the 5 milligram dose, which was very ineffective, is there something we can learn from that in terms of the peripheral CB1 role, peripheral CB1 central role? So what I'll note is with rimonabant, there's a large difference between the Cmax and Cmin, so we shaded that in red so you can see this. And I'll just draw your attention to its own IC90 here in red. And what's evident, while transiently below, daily doses certainly help to exceed that IC90. So you're kind of right on that threshold, but certainly exceeding the IC90 with the 5 milligram dose of rimonabant. So our thought is if central inhibition was critical to efficacy, certainly there's enough rimonabant in that central compartment to drive some level of efficacy, but we just don't see that. We see a very ineffective dose, as Dr. Aroni just noted. And in contrast, when you look at monlunabant, which is here below, much tighter PK profile where Cmax and Ctrough are right on top of each other, you can see that it, in relation to its IC90, is well below that. So again, very effective therapeutic and an ineffective therapeutic that has a lot of CNS exposure. Again, hammering home that point that the rimonabant central inhibition is not a driver of real efficacy, but instead promotes the neuropsych AE. And so the last way, I want to just pivot to real quick, is the inverse of this, and that is the peripheral exposure. And this is sort of coming back to what we just walked around with monlunabant. We're clearly above, in the periphery, above the IC90 values. But if you draw your attention to the bottom panel here, we're shading in the Cmin or Ctrough Cmax, you can see that we're well below the IC90 in this case. And so that seems to be a clear indication that at the 5 milligram dose, we're just unable to get that meaningful target engagement. So this likely, again, suggests that achieving the peripheral inhibition is the key driver, not so much the brain exposure. Okay, and the last piece with this modeling I want to touch on is if we look at the ineffective 5 milligram and the effective 20 milligram dose, there's something we can learn there about that relationship of central versus peripheral inhibition. So this is the two doses here, and you can see 20 milligram and 5 milligram. Here we're just simplifying more optimal Cmax, and we're clearly above IC90 in both instances. So certainly meaningful target engagement. Yet when we go to the peripheral compartment, again, the story is clear that the 5 milligram dose is below that IC90 threshold, where the 20 milligram, which is effective, is able to surpass that threshold. So putting it all together, it's clear that central inhibition is not a meaningful driver of weight loss, whereas peripheral inhibition seems to be the key. So just wrapping up this portion. So the Novo Nordisk update, I think, clearly highlights the promise of peripheral CB1 inhibition. The 10 milligram dose drives efficacy. We think this is, at the current time point, superior, or at least comparable, to the high dose of rimonabant. And the small molecule approach shows dose-dependent increase in neuropsych and GI-related AEs. The peripheral inhibition of CB1 driver is the key to weight loss. So monlunabant and rimonabant show clear peripheral inhibition, well above IC90 at the effective doses. That's 10 milligrams or 20 respectively. However, at 5 milligram dose, which had minimal weight loss benefit, is unable to achieve that IC90 in the periphery. and has notable central exposure, certainly more than monlunabant. And conversely, central CB1 inhibition drives neuropsych AEs without impacting weight loss, as we just walked through. The higher dose of monlunabant increases central exposure and frequency of neuropsych AEs in a dose-dependent manner. Central exposure of rimonabant is significantly more than monlunabant, yet lacks the same magnitude of efficacy at that similar 16-week time point. And both doses of rimonabant achieve IC90, yet only the efficacious dose is able to drive that meaningful peripheral IC90 threshold. So the question remains then, I think we have a compelling argument, but we need to think about, can a truly peripheral restricted molecule like the nimacimab reduce weight? And that's the question that we're going to try to get at today with our DIO model. Before that, though, I'm going to hand it over to Dr. Aurora to walk us through some of the interesting preclinical data that helps bolster that argument. So I'll come back in just a minute and walk us through the DIO data, but first, Dr. Aurora.
Good morning. I'm presenting this data to you on behalf of Dr. Marcus Gonzalez, who couldn't be with us because his flight was delayed. And hopefully I can take you through his presentation and show you how a peripheral restriction of the CB1 receptor is critical to some of the effects that we're trying to get at here, just the key one, of course, being weight loss. And I think Chris introduced this concept to you, and you'll see in the models that come in here the difference between what happens when you block CB1 in the CNS and in the periphery, and how peripheral restriction itself is meaningful in terms of getting at these metabolic changes. So we can boil down the whole idea of weight loss and metabolic well-being into energy in and energy out, and how much you consume and how much you spend. But behind all of this is a complex interplay that takes place in a variety of different organs. Now, we're in San Antonio, so I'm going to channel Ralph DeFronzo. We used to think of all metabolic disease before we focused exclusively on obesity, like we're doing now, in terms of diabetes, for example, being a triple-legged stool. And we would talk about the pancreas and the liver and the muscle being critical organs. And then we expanded our understanding and added adipose tissue once we realized that it's a living organ. And there's a whole lot of different adipokines that are contributing to metabolic well-being and certainly to weight modulation. And now we know the importance of the gut, which also produces a significant set of factors. And all of this goes on to communicate with the brain. So we have a gut-brain axis, and all of these work in coordination. All these peripheral organs together communicate with the central nervous system and help to modulate weight. And we'll see as we go along the importance of this peripheral system. The point I want to make to you before we go ahead is that CB1 receptors are actually seen in each of these critical organs, which are important to metabolic well-being and to weight modulation. So we'll start by looking at this DIO model. These are just mice that have been fed a high-fat diet, so they're made into obese mice. And we can look at what happens to these mice when they're wild type, and what happens when we start blocking CB1 receptors in them. And I hope that that will set the base for looking ahead at what happens when you start to restrict CB1 in both the peripheral and the central compartment, or both together. So very simply, if you take mice, these are wild-type mice. You can see nice steady weight. They're not obese mice. The same mice, when they're fed with a high-fat diet, are obese. Through the 4 weeks of this experiment, if you just leave them, they keep their high weight. Now, the question is that if you block the CB1 receptors, what will happen? And what will happen if you block them only in the periphery versus blocking them without any restriction, which means now you have a central component to it? If the central component of blocking CB1 was critical, then you would see a difference between the weight loss in these two models. And presumably, if the central component was important and was required with peripheral restriction, then you would see more weight loss in the non-restricted models. But here, you can see an identical trajectory of weight loss. So just restricted peripheral restriction of CB1 causes a very nice trajectory of weight loss here in these mice, exactly the same as when there's CNS action as well. Now, when we look at the effects of these, you can see right next to it that fat mass is decreased significantly in these mice with just peripheral restriction, and lean mass is preserved. Now, what is the outcome of this? You can see on the plot that's next to it. We'll start with insulin sensitivity. So what happens here is that you give these mice insulin, and the insulin is injected intraperitoneally. Insulin reduces glucose, so you can judge how well insulin is working, so how much insulin sensitivity they have by seeing how much the glucose comes down. And here we can see in wild-type mice, there's an exuberant reaction to giving them insulin. The glucose will come down substantially. When these mice become obese, on the other hand, the insulin stops working. This is what we call insulin resistance. You can see the substantial reduction in glucose lowering. When CB1 is restricted only in the peripheral compartment, we practically restore this insulin sensitivity, which comes now close to where it used to be in wild-type mice. And this is just peripheral restriction. Now, the corollary to this is looking at leptin, because these days we talk about leptin resistance as well, and that's important. So what leptin does is, when you eat, leptin is secreted from adipose tissue and signals to the brain and tells the brain that you're full, so it's a satiety hormone. When leptin stops working, you don't know you're full, so you will overeat, right? So the importance of just putting it very simply, that's the importance of leptin. Now, in the wild type state here, this is standard diet vehicle mice. So they're fasting, they have a little bit of constitutive leptin. When you feed them, the leptin goes up, and you can see that it goes up many-fold, and so this action of leptins causes them to stop eating. When these mice become obese because they're being given high-fat diet, the constitutive leptin is so high, it's higher than what happens in these normal-fed, non-obese mice, even after they're fed, that the leptin saturates its receptor, and even when these mice feed, you can't get that kind of a fold change, and therefore these mice become leptin resistant. So you no longer have the action of leptin the way you would want it. However, when we have peripheral restriction of CB1, you can see that we restore this initial signaling of leptin back, and now you can see a more significant change after feeding. To talk more about leptin, let's go on to see this other model. Now, here what we're doing is we're giving mice leptin, and mice respond to leptin really well by losing weight. So you know that the leptin is acting. So that it's a really useful model here. So we have these wild-type mice, and leptin is added to them, and you can see how their weight goes down really nicely. When they become obese, on the other hand, they become leptin resistant. So this action of leptin is lost. But when you restrict CB1 in the peripheral compartment only, so this is brain sparing, you can see how the action of leptin is restored, and once again, you get this significant weight loss with leptin. So by peripheral restriction here, we are restoring both insulin sensitivity and leptin sensitivity. And this just shows hypothalamic signaling here through pSTAT3. So it's showing you what's actually happening with that leptin. You can see that in high-fat diet-fed mice who are obese, there's no signaling, there's no pSTAT3, even when you give them leptin. But when you give it to mice in whom there is peripheral restriction of CB1 receptors, you can see here that the leptin signaling comes back. So we have central effects and we have peripheral effects, and we've just seen from these DIO models that the peripheral effects of blocking CB1 are actually significant when it comes to insulin sensitivity, leptin sensitivity, control of weight. We're going to see this in another way now, because the opposite of what we were just seeing is that you can actually block the peripheral action in specific tissues and then see what the importance of that is. So we're going to look at models where CB1 is specifically blocked in adipose tissue. And this is a really nice model of that. So these very young mice have their CB1 receptors knocked out in adipose alone. And they're very young, so as they start growing, you can see they put on a little weight and they become a little bigger, and now they're put on a high-fat diet. And in the normal mice that have CB1 action in adipose tissue, they put on a lot of weight. You can see that clearly here. But in mice that don't have CB1 in their adipose tissue, the weight doesn't go up. It remains more or less stable. So, and you can see that in this nice image on the side, it just shows you adipose tissue is tagged here, and it's a PET scan, so you can see how there's adipose deposition everywhere with high-fat diet, but almost nothing in the knockout mice. So the loss of CB1, specifically in adipose tissue, appears to protect these mice against obesity, again underlying the importance of peripheral action, or the peripheral action of CB1. So in these mice also, in these knockout mice, you can also see here that they eat a little less, but I think this is a really unique piece that is not just an anorexigenic effect. At every level of weight, the energy expenditure in the knockout mice is higher than that in the wild type mice. So what knocking out the CB1 does is allowing your energy expenditure to be higher. We know that when you eat a lot, your energy expenditure goes up because the body's trying to keep the weight stable. But when you lose weight, energy expenditure goes down, and that's one of the key reasons why people regain their weight. If you can keep the energy expenditure up the way we are seeing here, then that effect goes away. And this is being done here as just to underline that by simply restricting CB1 in adipose tissue. So we have a coordinated effect of this peripheral CB1 restriction. We just saw that in adipose tissue, when you block CB1, you get low food intake, high energy expenditure, loss of fat mass, and reduced leptin with increased sensitivity to leptin. If you do the same thing in the liver, you get high insulin sensitivity, less steatosis, even in obesity, and and leptin sensitivity. Similarly, in the GI tract, there's less preference for fatty food, and and gastric transit slows down as well. And very interestingly, and we just saw this with energy expenditure in muscle, if you at the same weight, these mice will eat a little more when you knock it out, which tells you that the energy expenditure has actually gone up. And we saw a little bit of that. And there's improved insulin sensitivity, and these mice can run longer. So peripheral CB1 inhibition is really important as a therapeutic modality. And a blockade in peripheral tissues promotes insulin and leptin sensitivity, reduces adiposity, and caloric intake. This is all while increasing energy expenditure. The CNS exposure of CB1 inhibitors is not required. The peripheral blockade of CB1 alone is enough to get the meaningful weight loss that we are seeking here. Unlike peripherally restricted small molecules, and Dr. Aroni talked about this a little, which will leak a little bit into the CNS, raising this question of what the contribution of the CNS effects is, nimacimab as an antibody is restricted to the periphery, and we've seen that peripheral restriction alone causes significant weight loss and improvement in various other metabolic parameters that go with it. And peripheral modulation of the CB1 pathway is therefore a fundamental therapeutic approach to address obesity and other metabolic disorders. I'm going to hand it back to Dr. Twitty to go through some more really exciting data here.
Okay, so I would argue there's a strong body of work that really supports this concept of peripheral inhibition that we just walked through. The knockouts go a long way. There's always a little bit of a question mark about secondary effects. The small molecule data is great, but there's the potential for exposure in the CNS. So really the definitive question revolves around this highly restricted nimacimab. We just haven't been able to generate data and answer sufficiently the question of can a truly restricted molecule like nimacimab be efficacious in a model of obesity? And so the challenge really stemmed from the fact that nimacimab does not cross-react with the murine or the mouse version of the CB1 receptor. So what we needed to do was generate an engineered mouse, that is a knock-in of human CB1, so that we could create a standardized DIO model. This mouse essentially allowed us to address this in vivo efficacy and really look at the response in a DIO model with the nimacimab treatment. Okay, so the model itself, as I said, it was a knock-in. We used male human CB1 mice, and we use N equals 8 per group. The mice were confirmed homozygous for knock-in, as well as some testing to make sure the CB1 axis is functional. And then we had an induction period where the mice were treated at 45 grams approximately. We measured, of course, weight along with associated biomarkers. The obese mice were treated at a Q3D for 35 days with the following doses: 7.5, 24, and 75 mg per kg of nimacimab. We also used the 10 nanomolar per kg sub-Q of semaglutide at the same schema at Q3D. And again, we measured weight, food intake, and associated biomarkers, included these points below here. Lean mass, fat mass, as well as glucose tolerance, insulin, and glucose-induced insulin released. Additional biomarkers included some of the critical hormones noted here. As well, we looked at inflammation as well as through cytokines and adipokine levels. Serum trigs and other lipids were assayed. And as well, we have IHC to understand better steatosis, inflammation, and this idea of browning, which we think is quite important. So these are underway. Today, we're not going to have this data for you, but we look forward to sharing that as soon as we can. Okay, on to the model. So first, just a brief slide to show the characterization. We confirmed through PCR that we have homozygous, in this case male homozygous mice. You can see that through PCR. We also wanted to make sure that the axis is functional. So we did this by using a TH-induced hypothermia model. And you could see relative to the parental wild type mice, the knock-in mice here have a very similar profile of THC-induced hypothermia at a couple different doses. The other way of looking at this is, as Dr. Orr just walked us through, we know that having a functional CB1 axis is paramount to inducing weight gain in a high-fat diet scenario. And here you can see that that is about the same magnitude and sort of kinetics, if you will, of generating an obese mouse. So we confirmed that both ways relative to the standard diet. Okay, so this is our data around the dose-dependent weight loss with the nimacimab. You can see that we do see significant weight loss at both the 24 and 75 mg per kg. We have a little bit over 11 and 16% weight loss. If we look to the right, we can see that this is aligned with the body composition data, whereby fat mass is trending that same direction with significant loss at 75 mg per kg. And not a significant change to body composition. If we overlay semaglutide at that dose, we can see this is really benchmarking our model in terms of what we might expect with this, I would argue, the suboptimal dose, still an effective and active dose, but suboptimal dose of semaglutide at 10 nanomolar. This bounces around. The sawtooth pattern is fairly common, and we see that this is moving somewhere between 5 and 10% in terms of its body weight loss. I would note that the high dose of nimacimab is significantly different, but we're not. The purpose of this study wasn't so much to make the claim that we're somehow superior to semaglutide, but just benchmarking on it. So it's important to come back to as we're going to be developing this model further. I would note it's interesting here that semaglutide also had significant fat mass without a lot of lean mass change in terms of body composition. We've seen this elsewhere. I think it might be related to this less than optimal dose of semaglutide. So we're looking to change that to maybe a 30 nanomolar per kg in upcoming studies. So the other thing we wanted to look at was some of the glycemic indices, and importantly, here looking at glucose tolerance test, you can see again a similar dose-dependent response in terms of looking at the blood glucose levels. So both 24-75 as well as the semaglutide were able to reduce those compared to the high-fat diet vehicle. And if we took the area under the curve baseline subtracted on the right, you can see a very similar pattern, again suggesting that the nimacimab treatment is able to provide this benefit. So to summarize this early data, we've developed a human CB1 DIO model to evaluate nimacimab. We have a targeted knock-in, and the CB1 signaling is functional. This initial data demonstrated significant efficacy. It's dose-dependent. It's associated with fat mass reduction. There's a dose-dependent glycemic control. and the analysis of serum lipids, steatosis, fibrosis, inflammation, et cetera, are underway. And the next steps, we're going to be looking at a few things, but what's important is that our PK analysis is underway. We feel there's going to be a load phase that's happening right now, so it's really important that when we look back at the data, those first 5 or so days are really critical to getting that IC90 threshold met, getting real target engagement initially in these compressed DIO models. So we're looking at ways to achieve that more readily, including, of course, the dose, but looking at route and timing. These will be important to achieve a more optimal and potentially translatable model. So additional preclinical studies are underway, and we're looking forward to sharing that data as soon as we can as well. So broad conclusions, the modeling and the DIO data effectively suggest that efficacy of peripheral inhibition is the key driver. Central does not seem to be the driver of efficacy. We have improved safety, so the central CB1 engagement remains a key liability for all small molecule inhibitors. I think we're going to have to do better than a 10-fold difference in restriction. I think the order of magnitude we're looking at 600 or greater is, I think, where we need to be for real to remove that safety overhang. With that, we're still able to achieve that peripheral inhibition that's required. So we're able to check both of those boxes. And finally, as we're saying, the critical role of peripheral inhibition, significant dose-dependent weight loss, fat mass, and glycemic are all part of that. We're excited to see other mechanisms at play, but we feel all those can be driven from our molecule. Okay, I'll hand it back to you.
All right, thanks, Chris. Appreciate that. So we have some time for questions from the presenters and panel. There's 2 microphones there, so please just stand up and we can take questions in an orderly manner.
Good morning. Ted Tennell from Piper Sandler. So firstly, bravo, masterclass on CB1. Dr. Roney, I had a quick question for you. Just looking back, and this may be putting you in an unfair situation, so I apologize for that. But looking back, would you say that the suicide risk of rimonabant warranted removal from the market? And if you kind of roll that forward to where we are with monlunabant, does that current level equal similar concern in your view? I don't know if we have enough data yet to answer that.
We definitely don't have enough data yet. You know, the FDA will be skeptical of the CB1 mechanism as a result of that. I mean, there's been a lot of debate about the rimonabant development program and how, whether this was really there or not. I mean, people getting a depressed mood from taking medication is something that does occur. It's suicide that is absolutely unacceptable. And, if someone has a depressed mood as a result of medicine, you stop it and it goes away, well, that's one thing. But, no one wants to create neuropsychiatric problems. We want to help people to get better. So I think that anyone developing in this area, if there's any type of signal of neuropsychiatric side effects, will have to prove that it's not there.
I appreciate that color. And then I know this isn't the focus of today's event, but just to ask, you guys mentioned that we'll be somewhere around half enrolled by year end. Can you give us a sense of how enrollment's going? Any feedback from investigators? And what should we expect from that initial data set next year, both in terms of nimacimab versus placebo, but also with only about 20 patients or so doing the math in the combo arms? What do you think we actually can discern from that data set? Thank you.
So I'm just going to address the enrollment question first. And actually, enrollment is going very well. We've been very pleased with the response. As you know, we had selected 18 sites across the U.S. So this is a trial in the U.S. Almost all our sites are up and recruiting and have patients. We've heard a lot of excitement and enthusiasm from our investigators about recruiting for the trial and participating, and even the concept that we're doing both monotherapy and a combination arm with a drug that's known to have effects. So all of that has seems to have gone down well. We are looking forward to meeting these milestones, just as you said. So we're well on target. So we are very excited about that. So when we come back timely with these results, initially, yes, as you pointed out, the numbers will be low. It would be really nice to see differences at that point, but with the combination arm, there will be 10 and 10 patients. So hopefully we'll get to see some signal. With that, we'll just have to wait and see how much variability the data has. But certainly, once the full data set is available, we should be able to get a much more meaningful response.
Again, thank you for the good overview. But I wanted to also kind of get to the point of the leptin resistance part. And that is supposed to be the data that was presented in the animals. It said it was peripherally restricted CB1. And it's affecting leptin resistance in the brain, I'm assuming? That was in the brain? So, and I'm assuming that these animals were eating less. What is the data that we have with the nimacimab with the food intake? Because I didn't see the data there. Is it actually changing food intake also?
So what we've what we found was that it was very similar. The semaglutide and the two doses, the lower doses of nimacimab were very similar. There was a significant increase or reduction rather in food intake with the highest dose. The caveat is we didn't collect the first 5 days, unfortunately, which is, as you know, quite critical in these DIO models. But from day 5 onward, cumulative food intake was significantly impacted at the highest dose relative to semaglutide and the other two doses. Preliminary data, we obviously want everything to be at the highest caliber before we show this, but that's being transparent, that's what we've seen. So there does seem to be an effect.
And do we have a mechanism why we think that leptin resistance might change in these animals? Again, if it's completely peripherally restricted?
Well, I think the data that Dr. Aroni walked us through, which was a complete inhibition just in adipose tissue, where we think obviously leptin is such a key driver, we feel that that's a large, the reduction in that tissue can help modulate and reduce leptin. And in terms of sensitivity of signaling, that's another area where clearly there's information where CB1 can increase PSTAT-related leptin-based signaling. So we feel that those pathways are relevant, although generating a knockout, we'll need to prove that in our own models. But we feel that's relevant and likely to translate.
Thank you.
Hi. I'm Catherine from Citizens JMP. I had a quick question just about the model itself. And how does a DIO mouse model compare to a DIO rat model? Do you expect kind of any differences? And how does this data benchmark relative to some of the other DIO studies that we've seen? As far as like the semaglutide arm losing 5 to 10%, is that sort of what you're seeing in the field?
Yeah, great question. So the rat mouse is a bit tricky. I'm trying to think if I'm not aware of a direct head-to-head comparison to see how those translate, other than the small differences in allometric dosing, et cetera. But in terms of behavior, it's a fair question. I can't provide a lot of insight to that. So in terms of the performance comparison of semaglutide, which is a benchmark, what I've found is that this model is potentially a little more robust in that I've seen others reporting more at that same Q3 10 nanomolar semaglutide dose, having a little bit more weight loss. So something in the order of more like maybe 10 to 15 as opposed to ours being 5 to 10. Take that, I mean, this is early data, we're going to be repeating everything, but it seems that people have achieved more weight loss with the same dose in a similar DIO model.
Thank you so much.
Just one quick one from me. So William Wood from B. Riley Securities, very nice presentation. I'm just kind of curious in terms of, it may be sort of getting a little bit ahead of the overall, sort of where we are in the program, but have you started looking at maintenance dosing or potentially even, monthly or bi-week or every twice a week, sort of see if we can stretch this out past that initial robust weight reduction we're seeing? And then obviously you're testing it in combination with semaglutide, but there's numerous other molecules coming on the sort of the landscape or to market potentially. Maybe amylin comes first to mind, but just given the characteristics of what we've seen with CB1, then would there be, what do you think would be sort of the best pairing if you sort of could choose your potential partner to actually make sort of a combo, like sort of thinking like a CagriSema or something like that? Just love to hear your thoughts.
So it's a great question. We use SEMA in these combinations because the GLP-1 mechanism has now shown independent effect on cardiovascular disease reduction and other effects. So I think that GLP-1 is kind of the standard of care for now. I think that other mechanisms like amylin, I did studies of amylin for weight loss in conjunction with other molecules 20 years ago. And so amylin is always going to be a very good molecule to combine with something like this. So I think that an amylin CB1 antagonist combo would be probably very effective. So I think that there are a number of ways to go. I think that, we've talked about CagriSema. You see about CagriSema, but I think that having these things as independent agents is going to be where we go, so that these can be combined when necessary to produce greater weight loss. I think that's the way the field is going to head, so that you can do it. Again, just like blood pressure medicines, diabetes drugs, and other metabolic treatments, you can put two mechanisms together to get a much better result.
Just real briefly, I think you might have been addressing the DIO model too, as well as the dosing there. So, we're running a PK study to better understand the AUC and how we might elongate, to your point, some of the dosing, or even compress or look at other routes, as I mentioned, to really get that meaningful engagement early. So this is obviously a very compressed model relative to our 6-month model, but I think that's all in the works, and we'll be looking at those questions. Thank you.
Hey, this is Dennis with LifeSci Capital here. Great presentation. Thank you so much for taking the questions. Mine is, it looks like based on the PK modeling, monlunabant 10 milligrams is above the IC90 for CB1 in the periphery. And they noted limited additional weight loss above that 10 milligram dose. Curious if you think that 6% weight loss at 16 weeks is kind of the max we can see with the CB1 mechanism.
I don't think so. So, it's a great question. I think that, the central CB1, what you've seen is that, doubling the dose is not giving you much more weight loss, but maybe giving you more side effects. So if you're peripherally restricted, you can probably give a lot more, and you may be able to get greater efficacy without having the side effects. So I think, we just got to try it and see what happens.
Yeah, just to add to that, I think the nimacimab, where we have an advantage there over the small molecules, is definitely the therapeutic window is much larger. So you're hoping that through the peripheral mechanism, we're able to still drive these other broader glucose regulation, lipogenesis, other factors that should be able to drive even more meaningful weight loss.
And maybe I'll just add too, it's clearly speculative, but if you look at the trying to overlaying the phase 1 dose and different subsets, so we don't want to overinterpret, but just overlaying the Rio sort of curves. What we currently have, one data point at 16 weeks, at the time point at 4 weeks. So again, very just being cautious here, but it would suggest that curve, if followed, is still has some room to run, and we'll see what the depth is. But I think it bodes well for further weight loss.
Great, thank you.
For Dr. Roney, we had one follow-up question. Just you went over some really compelling experience with rimonabant, especially with the monlunabant data that just was announced, and now we're still waiting for 52-week data. What do you anticipate in terms of how Novo is going to be managing, how do you think they're going to be managing, if they continue to see good efficacy like they're seeing, but also some level of safety risk, as has been evident in their press release, how do you think they'll translate that into further clinical studies?
Sure. I think that, again, this is not specific to Novo, but the FDA, given the history of this category, is going to be skeptical. And the thing that really killed the other agents back in the 2000s was that the FDA had asked for a trial, an outcome trial, to prove that there was not suicide, like that the other compounds didn't cause suicidality. And that was a very, very large trial. I think that in the presence of neuropsychiatric events, that they may ask for some type of staged approach to prove that it's not there at some level. I don't think that they're going to want the same type of massive trial. I think that they'll look for signals before that. There are a number of signals that can be looked for, but I think that that it's going to be up to the compound sponsors to prove that these drugs are safe.
Yeah. Thank you, Dr. Roney. So that concludes today. Is there any other questions? All right. Well, we appreciate everyone making it out. It looks like we made it in time with the 8 a.m. finish. We'll stick around here to answer any other questions or have any other discussion. Appreciate everyone making it this morning. Thank you.